PDA ligation is the commonest surgery that we do at the Heart Institute, and the standard of care, we routinely insert a chest drain when closing the chest. But the next slide. The problem with the method we're using is that it predisposes the patient to more postoperative complications and may increase the cost of surgery. And in justifying my study, there's controversy over routine using the chest tube. And in a situation like ours, where there's low income and skills are also low, we thought not routine using the chest tube may avert complications and also reduce costs. So my general objective was to compare the postoperative outcomes of chest closure in those where we don't use the drain and those where we use the drain. And specifically, I wanted to compare the postoperative complications between these two groups and also to compare the length of ICU stay. So my research question was, does closure of the PDA without a drain reduce postoperative complications? And my null hypothesis was that there's no difference between these two groups, whether we use the chest drain or we don't use the chest drain. So this was a non-blinded randomized control trial, and I did it at the Heart Institute, which is the only place where we carry out surgeries. And I estimated a sample size of 86 using Pocock formula, and we planned to do intention treat analysis, and we planned for 2 analyses, 1 interim and 1 final. So that table just shows that we used 0.029 as our p-value because we did this is an interim analysis I'm presenting. Next slide. It's not working. Okay, so it took me 1 year to get 44 patients, so my recruitment was really slow. I did consecutive sampling, and I randomized 44 patients, 20 to the drain arm and 22 to the no drain arm, and I randomized after PDA ligation had been done. So I included every child 12 years and below, that's the pediatric age in a hospital, and I excluded anyone who had bronchospasms preoperatively, anyone where we're doing another surgery other than PDA ligation, and anyone where we noticed we had damaged the thoracic duct or the ductus arteriosus itself. This is my table for baseline characteristics, and there's really no difference between the two groups. And the next slide, the graph next just shows that the two groups were comparable. And also, I wanted to ensure, the next slide, the intraoperative characteristics, wanted to make sure both groups were exposed to the same conditions. And the next slide, we show a graph will show both the drain and the no drain arm had similar intraoperative conditions. Okay, I'll spend a little more time on this slide. I'll just mention that my endpoint was a combined primary endpoint where I had significant pleural-space accumulation postoperatively, or low oxygen saturations or surgical site infections. And my secondary endpoint was a prolonged stay in the ICU. Now, if we look at the first pleural space separation at 48 hours, the patients in the no drain arm, one patient developed a complication. It was we didn't notice that the thoracic duct had been damaged, so this person had to have a chest drain inserted postoperatively, and this didn't happen to anyone in the drain group. But the difference was not statistically significant, and we did not reject the null based on that. So, and then surgical wound infection in the drain arm, 5 people got purulent discharge at the surgical site. No one in the drain arm had such an infection, and the difference was 0.048 was not statistically significant, so we didn't reject the null here. Okay, I won't go through all of them individually, but when we looked at the combined primary endpoint, no stands for no drain and yes stands for drain. So we did an odds ratio, and it was 0.15. So people in the patients in the no drain arm were less likely to develop complications, and even after adjusting for confounders, our odds ratio was still low at 0.13, and the statistical significance was there. Then ICU stay had wasn't affected by the drain or no drain. My limitation is that I had selection bias because I only got patients who came to the Heart Institute. We didn't go all over the country, and my numbers are small, so I can't make strong recommendations at this point. Next slide. So from our data, 95.5% did well without the drain, though one patient got Complication, that's 4.5%, but this patient underwent an eventful tube insertion and did very well. Another study had 95.5% of their patients doing well. Next slide. So this is one of my patients, a child of 1 year who had a chest tube inserted post-operatively. Next. And you see this only 28 mils of fluid was drained. Next. This is the ultrasound that shows how I measured my fluid in the chest post-operatively. Next. So from my study, it's children in the drain arm may need more oxygen compared to those in the no drain arm. And ICUC was really not affected whether you had a tube or no tube. They both did well. Next. So the evidence suggests that avoiding routine use of the drain after uncomplicated PDA surgery is safe. Uncomplicated meaning that you did not damage any of the intrathoracic structures. And then children who routinely received a drain were prone to getting complications. Most of them had increased pain, most of them oxygen saturations were low, and then there was also the surgical site infections. But I mentioned at this point, most of my patients were 6 years and below. I had very few patients who are above 6 years, so my recommendations will not may be more for the younger children below 6 years. But I'm still continuing with this study, and once I get all my patients, I will give another report. Thank you.